long break. So we have, just to recap everything we have done, we have seen the overall PNF concept from history to development of the techniques to the overall concept, looking at the philosophy, looking at procedures, techniques, patterns, and so on. We have looked at various patterns of upper limb. We have looked at the first diagonal inflection direction. We have looked at the first diagonal in extension direction. We have looked at the second diagonal in inflection direction. We have looked at the second diagonal, D2, in extension direction. We have looked at the scapular D1, anterior elevation and posterior depression. We have looked at the scapular D2, posterior elevation and anterior depression. We have looked also similar pattern on the lower limb, the pelvis, D1, D2, posterior elevation, anterior elevation, posterior depression, posterior elevation, anterior depression. If you look at the D1, D2 for the lower limb pattern, we have seen the D1 into flexion, D1 into extension, D1, D2 into flexion, D2 into extension. We have also looked at various combinations of scapular pattern and pelvis. We have looked at various combinations of upper limb, bilateral upper limb combination together with upper trunk, which will have the chopping and the lifting. We have seen combination of this is an example of scapular pattern, anterior elevation. Okay, this is just posterior depression and posterior depression, as you can see. Yes, so this is now anterior elevation downwards and posterior depression. Yes, we could see combination also anterior elevation and anterior elevation of scapular and pelvic pattern. Then we've seen the lifting and this is an example of lifting. We'll see the leading arm and the lagging or following arm. We'll see the chopping, where we have the leading also and the lagging arm. We've seen also the lower limb combination of the trunk. Last time we talked about documentation of PNF, in which we look at, well, generally while documenting, you should be able to tell the starting position you have applied the PNF concept, the various principles you have applied, the various techniques, and the various patterns. That is when you have complete documentation of PNF. Just go through it in brief. Then I think we have discussed the two types of agonistic and two types of antagonistic techniques. Then we can, I think with this, we can go through one of the topic that we need to look at today before the time elapse. So let's look at math exercises. Math exercises are very, very important. All the time, though I'm not purely in the clinic, I manage patients a few times after I moved to the academics. But while I was fully in the clinic working, any patient that usually comes, I most times start with math exercises, all the scapular patterns, the pelvic patterns, the combination of scapular and pelvic patterns, rolling, activities in sitting, and many other things, because everything I'm doing and on the mat in lying position, I'm targeting also various activities, especially even gait. So right from mat exercise, you can target gait rehabilitation. That is most time our overall aim, even though we have also aims of improving upper limb function and many other things. But without trunk function, without the upper limb function, without the lower limb function, the gait will not be effective. So the trunks stand as serve as the pivot, that the upper limb function, the lower limb function. So if you have a weak trunk, the best thing is start with mat exercise and the scapular pattern, the pelvic pattern we have demonstrated, the combination of upper limb and scapular patterns, combination of lower limb and scapular patterns are very excellent exercises for trunk. Yes, coupled with other things. So mat exercises are very, very important because they offer unlimited or unrestricted possibility for movement. Unlike you take activities on the couch or you take activities on the um, standing, sitting, and so on, there is more possibility for patient to do that. And we remember, if you remember in the philosophy of PNF we have mentioned at the beginning, is making sure the patient is able to carry out many activities. We will start with the activities that is able to carry out. Instead of just standing the patient, the patient cannot do anything standing, or sitting the patient, it's better you start with where he can do a lot, where he can achieve a lot. Then you move on and graduate. You strengthen those things and move up. So patient feels safe also. There is no feeling that is going to fall down. There is no feeling of injury, feeling of all those feeling, the lack of security and are not there. And also opportunity to do a lot of functional things on the mouth, on the mat. Then you could also manage more than one patient on the mat because there is much safety. Unlike they are standing or they are sitting, you know that there is let me say minimal risk of injury because they are all at lower level. So you can have as many as possible to be exercising at the same time. And like I said, mat exercises are aiming at preparation for GIT. So there are some guidelines that will help us in administering mat exercises. And one of them is to obtain a new position with a patient. You start with, for example, lying position, and you make sure that patient is excellent in lying position. And how do you make sure we do that is carrying out function in that new, making sure he's stabilized, he has the strength to maintain that position. So training for strength, coordination to maintain that position, that will be your main target. Then the next thing is you carry out functional activities in that new position. Then you start from easy tasks to more difficult tasks. You make sure the tasks that he's able to do, the position he's able to achieve, even if it's lying down supine, you achieve all the things you want to do there. It's better you do it than you go to activities that you cannot do, and every day you come and do that, and that will be a problem for the patients. Then you go and end up with the highest that the patient can achieve. That will be the end of the exercise or the mat activity. So there are various positions that we are going to carry out this exercise. They involve rolling. They involve rolling from supine to prone. They involve also returning from prone to sideline, from prone to elbow position, from prone to prone on hands, to quadruped position, to side sitting, then to kneeling, and to half kneeling, then to standing up erect. Then in supine lying, rolling from prone to supine, then roll from supine to side lying, then from supine to side sitting, then to scooting in the side sitting, and also from side sitting to quadruped position, from side sitting to long sitting, from scooting in long sitting, short sitting, then scooting in short sitting, then getting to stand up. These are some of the starting positions that I've just mentioned. We will see on the picture, supine line. Then we'll see side line. We'll see the quadruped position. we'll now see the patient on elbow. Then we'll now see the patient coming to sitting on the heel, then coming to kneeling position, and coming to half kneeling position, then standing, then long sitting, side lying, and so on. But when changing position from supine, from prone lying to sitting, for example, from supine position to prone on hands, we could see a chart here showing flow of movement from one posture to the other, or from one starting position to the other. For example, from prone lying to side lying, or from prone lying to sitting with straight leg, or from side sitting, or from side lying to side sitting position to side sitting, and so on. Also notice the type of contraction that also need to notice the type of contraction the muscles are carrying out while moving into this position. I gave example while last week and also this week while demonstrating eccentric concentric muscle contraction. You ask patient to squat or to sit. You make sure he's sitting, eccentric contraction of the quadriceps. He's standing, concentric contraction of the quadriceps, so and so on. So we go in with concentric muscle activity, then we go out with eccentric muscle, and so on. So we also need to determine the type of contraction that those patients are involved. So these are some examples here. We have here somebody on the mat here, and we have pelvic and scapular pattern exercises being conducted. We could see here the first one here is preparation into rolling. And we could see anterior elevation of the pelvis. The lady is lying on sideline on the elbow, and she's carrying out anterior elevation of the pelvis in preparation for rolling. We could see also on the same sideline posterior depression of the pelvis, also on sideline. We could see also a combination of same side posterior depression and anterior elevation, posterior depression of the scapula and anterior elevation of the pelvis. So any position you achieve, you'll be on supine line. What tasks, what activities that person is able to achieve that position, stability in that position, then what tasks are you going to carry out from those positions? So these are just an example on the sideline. So we could have various tasks on and on the sitting position, supine, prone, and so on. So we could see transition from let me cycle it also. We could see transition from position on elbow to quadruped position. We could see that the physiotherapist is giving resistance for going into quadruped position, and we could see the position, yes, is giving resistance. And we could see also another activity here. The physiotherapist is giving resistance to the neck to the neck flexion of the patient. So each position that the patient that we have mentioned, the starting position, that patient is stable in that position. You carry out activities and tasks, and also while transitioning to other position, you also carry out activities. be it a certain technique you want to apply, or you just want to resist to make sure you have given resistance to improve strength, or you want to even facilitate, you want to make sure it's going into that position easily. So you want to support, not just giving resistance. So it depends on the need of the patient. Yes, we could also see uh, also moving to quadruped from side sitting by giving resistance to the pelvis. So the patient will be trying to go into quadruped, and the physiotherapist is giving resistance to the pelvis, we could see, and we'll be going back. So technique like combination of isotonic is also possible. The patient is going in and coming back, going in out. So you have concentric, eccentric contraction, like I mentioned earlier in the flow chart there. This is lateral flexion of the trunk while the patient is in a quadruped position. So you have the patient going into tilting the laterally flexing the pelvis and laterally flexing the upper trunk also, going into flexion. And so you could see also resistance going into from quadruped position back to elbow position. You could see resistance that the physiotherapist is giving here. You see resistance at the pelvis. We now see resistance also coming back. So this will be also another technique that could be applied. So it could be also from transitioning from kneeling. We could see this, the patient is transitioning from one 1 point kneeling to standing position. I could see that the physiotherapist is resisting the movement up and also going back. Then you could also carry out upper limb activities. This is in supine lying position. This is just bridging, giving resistance to bridging. I could see also involving the anterior elevation of the pelvis, and also combining it with combined upper limb with bilateral asymmetrical upper limb pattern. We could see also knee half kneeling position together with upper limb activity. So it depends on the needs of the patient or the impairment. So we can combine all these things. Then we can now move to the gait. Some time is against, so this won't be too detailed. So we have gait. Everything we have mentioned about the maths and also the other activities we are doing, they are all towards gait pattern. So we look at what is gait. Gait is I'll be brief about the gait assessment and some other things. I'll go straight to maybe the facilitation. We have gait is the normal way of walking, is a pattern of walking or particular way of walking, and so on. Is also continuous avoidance of falling down. Yes, that is gait. That's just walking. Continuous losing and gaining balance. So, but there is need for gait to be economic. That means with little energy expenditure, with little difficulties, with easy posture and many things that could be conducted. So when there is pathology, all this, you see patients using all sensory inputs, all compensatory muscle involvement, and many other things that you have to do for them to walk, which walking is supposed to be just automatic. You shouldn't even think of how you should walk because you have learned that many years ago. You're just asked to stand, you just do that automatically. You're asked to walk, you don't even know that you have arm swing, you don't think of how you walk, and many other things. That should be part of it. But when you are asked to walk,
and you have to think, okay, what should I hold? Okay, I should have intense input from the visual sensory stimulus. I need to pay attention to what I'm to my feet. I have to look at where I'm going. I have to many of those things. Then it means it's not. It means there's a problem. So economy of gait must means that there is mobility and stability of the trunk and limbs against gravity. I've mentioned how trunk is very, very important. Also, the limbs are important, but trunk is the pivot. So ability to shift weight forward, appropriate range of motion in the limbs and spine, sufficient muscle strength, coordination of motion, motivation, and minimum energy consumption. So while you are training for gait, you are aiming for economy. What you do is make sure that the trunk is stable. You can maintain various posture with a very strong trunk. Lying down, sitting, standing, rolling, kneeling, and various positions. Then it's also mobile. You can make various movements, rotation, upper trunk rotation, lower trunk rotation, lateral side rotation, to lateral upper trunk lateral rotation, lower trunk lateral rotation, and various movements. And also making sure there is mobility on stability. Certain part of the trunk will be fixed and allow movement for another part of the trunk. Yes. Then the limbs also. The limbs are also mobile and they are also stable. They can maintain various posture. They can move, of course. Then they can also maintain various posture. So that's when you aim for economy. That means you can have a very good gait pattern. Then ability to shift body weight forward and also have a range of motion in the spine. That's the mobility of the trunk, of course. Range of motion in the limbs also. That's also mobility in the limbs. So also strength. Strength is missing in one of the components of the muscle. You also go for the strength. Which technique will you go and improve the strength? Then coordination. Which also technique will you go to improve coordination of the muscles also, or of the joint? So in all, a good gait pattern or a good gait will involve manipulation of various degree of freedom. We have up to about 100 and close to 30 or 20 degree of freedom as we are walking, because we have the knee, we have the hip, we have the shoulder, we have the trunk, we have the neck, we have the various joints that are moving, going in and out of movement for us to allow for a very good gait pattern. If we are reducing the number of degree of freedom, then it's going to affect the gait pattern. The more you remove certain joints in movement, the more you are going to have poor gait pattern, or you are going to have risk of fall or injury and so on. So how do we measure gaits? I will not go also detail into the measurement of gait. I'll just concentrate on what we will be looking at. Yes, we have various parameters. We have the spatial and temporal parameters for us to know that there's a good gait pattern. We have the spatial, like gait, step length, step length. We have stride length. We have step width. The temporal, for example, we have gait speed. We have cadence. We have so many things that we want to know. So if there's a problem somewhere, you're able to tell where the problem is on those parameters, and we go and manage. Yes. So, but what I want to take us is there are various classification of gaits. We have the conventional one, which we are very familiar with, which is what we just look at the activities of the foot. We say there is heel strike, there is a foot flat, there is a heel off, toe off, and so on. That is the conventional. But there is a Ranco Los Amigos gate classification. Yes, this is the conventional. We have hip strike, foot flats, mid stance, and push off. And we have the acceleration and deceleration and so on. But we have the conventional, sorry, we have the more newer one, which is the Roncos Los Amigos, which we have not just activities that's going on in the foot, but we have also activities going from head to toe. We look at what is happening in the coming up, what is happening at the toes, what's happening at the ankle, what's happening at the foot, what's happening at the ankle, what's happening at the knee joints, what's happening at the hip joints, what's happening at the trunk, the upper limb, the neck, and all those things. So that's when we find out that this is a particular problem of gait. So we have initial contact. So it's not just about the classification, it's about also knowing what muscles are involved. What is the range of motion for those muscles from particular phase of the gait to the other phase of the gait? Generally, we have the two phases of the gait. Yes, we have the stance phase and we have the swing phase. The stance phase takes about 60% of the gait cycle, and stance phase takes about 40%. That's around from 60% to 100% of the gait. So the stance phase take majority of the gait. So one of the secret is that you want to see a very good gait pattern, especially for stroke patients. You go for the 60%. You go for the greater percentage, which is the stance phase. You have a good stance phase, you have a chance of getting a better good gait pattern, because that's the majority of the gait pattern, of the gait cycle, sorry, the stance phase. We could see it start from 0 up to 60. And okay, we'll see the breakdown later. So we have the initial contact, we have the loading response, we have the mid stance, we have the early and the late mid stance, we have the terminal stance, and we have the pre-swing. Then we have initial swing, mid swing, and terminal swing, which are the phases of the phases of the swing phase. So I won't be able to go through all this to discuss it. But yes, I'll discuss.
Different audience.
Well, if they want, they can have access. You can calculate the notes how to calculate.
Different audience, different.
Okay, you are assessing gait. You need to look at the head position, you look at the neck position, you look at the arm swing, you look at the trunk symmetry, you look at the shoulder symmetry, you look at the foot clearance, you look at the patient, how when not just asking the patient to walk and come back, you ask the patient to walk forward, you ask the patient to walk backward, you ask the patient to walk sideways, and you see how the patient is responding. You can see that the balance is upset while he's going backward. You know that there's a problem with balance. You see it when the patient is going forward. But when you ask him to go backward, then you see a problem. You ask him to go sideways, then you see other problems. So you ask the patient to walk with footwears, without footwears. You ask the patient to walk on different terrains, on different environments in the clinic, on so you have anterior view of the patient, you have the posterior view of the patient, you have lateral view, you check for symmetry, asymmetry. That's where you know that there's a weakness somewhere, there's a problem somewhere, and those are the things that need to be addressed in the patient. I've mentioned the measurements, the parameters that you look at, the spatial, the temporal parameters, and you have some other direct motion assessments like the electrogoniometers, electromyography, podoscope, and so on. Yes, I want us to go straight into the facilitation. I know you are eager for us to go there, so that we can also take the practical for the math and also take for the upper limb. It's already 3 o'clock. Yes. So when we are examining gait, we also need to know that at 0%, that's when you have initial contact. From 0% to 10% is when you are transitioning into mid stance. You could see that transitioning from mid stance to terminal stance, you have around 20%. You also have from terminal stance to pre-swing, you also have about 20%. But from pre-swing to initial swing, you see just 10%. From initial swing to mid-swing, you see 10%. From mid-swing to terminal swing, you see 15%. Then so you could see that even though, yes, we have mentioned that the stance phase has 60%. You could see that mid-stance is one of the key. It takes about 20%. Also from there to terminal stance, we could see also another 20%. So mid-stance alone, from mid-stance to terminal stance, or from initial contact, hit strike to terminal stance, we have about 50% of the gate cycle already. So if you find out there's a problem with hit strike in initial contact up to the level of this, if you're able to correct this, you're able to facilitate, you're able to manage this, you're going to have about 50% of your gate cycle being managed. Then you go to the swing phase also and see what you want to manage there. What is the problem there? But now is about the allocation of each of the gate cycle. How important those things are. So we can still also here is still the allocation, but concentrating on the lower limb alone, we could see what are the muscles involved. At initial contact, we have the gluteus medius up to the 40% of this gate cycle. So that means you targeting gluteus medius for the hip will help a lot in managing your gate cycle. You could see also the gluteus maximus also from the beginning till 40% of the gate cycle. Tensorfascial lata up to 80% of the gate cycle. Then it's just 10% of the gates here that you are not seeing tensorfascial lata. So if we just be managing gates, facilitating gate just
serve as an anchor point.
Yes. Yes. So just managing it randomly, we are not targeting at the primary problem in the gate cycle, then we are going to have a lot of problems. We have the quadriceps femoris that we manage all the time. We could see it's just about 30% in the gate cycle. That is when there is a hip. When there is a knee involvement. Then the hamstring also similar because they have co-contraction. When they are working, we have eccentric and also eccentric function of this muscle going together and co-contraction. Then we have the gastrocnemius and the soleus muscle. We'll see also when they're involved. We'll see also where hamstrings has resurfaced again as its function towards the end of the cycle from 80 to 100%. We'll see quadriceps resurfacing at the last stage of the gate cycle towards the end of the swing phase. We see 90 to 100%. That's where it's at. So I want to break it down again here. Individual muscle, we see where we have period of double support. We don't see iliacus anywhere. It's only at the swing phase, at the initial swing. That's when we have the iliacus, the sartorius also getting involved. Gracilis is at the period of double support and also at the swing phase. Then all the muscles there, we need something to, we need to have this idea of which muscle comes where.
Yes.
And again, not just which muscle comes here, what range of motion is that muscle involved in that particular joint? Because you need to train it also in that particular range of motion. That is when you have the function you desire in that particular gait pattern. So we can see here from trunk, pelvis, hip, knee, ankle, and toe. We could see the range of motion for each of the joints, we could see that at initial swing, we have 20% of hip flexion. And we could see at mid-swing, where our 20 to 30 degrees of flexion. We see at terminal swing, this started with swing, sorry, not the stance phase. So we could see 30% of swing, 30% of flexion in the swing. Then, sorry, 30 degrees. Sorry, this is the range of motion. I'm mistaken. Sorry, it's not the percentage. It's the range of motion. There is 30 degrees also still of the hip joint at initial contact. That's we have now got into the into the stance phase. Yes. Then it still maintain 20 degrees. Then we will now have extension of the hip. Initially, we have flexion. Then we have now extension going into neutral. Then we will now have up to the end. We'll have knee joint also. The various range of motion from 60 degrees to 60 to 30 degrees. Then we have it at neutral position at extension of 0 degrees. Then we have full knee extension when you have initial contact. You have 0 degrees or you have full knee extension. Then going into loading response, we just have 15 degrees of flexion of the knee. Then it's going back into neutral in mid stance, then full extension and a bit flexion when it's going into pre-swing, going back to swing again, swing phase. Then the plantar flexion, the same thing, and the toes also the same thing. So knowing the range of motion also, knowing the muscles, knowing the range of motion of every joint, knowing the muscles, where they come in and where they go out, and also which type of contraction those muscles are involved. Is it eccentric or is it concentric? So we train for that also, based on the contraction that the muscle is involved. For example, if you are going into, as we can see here on this picture, you are going into, let me cycle, you are going from initial contact, hip strike, which you need concentric contraction of the dorsiflexors, right? Yes. But while you are going into loading response, what you need is eccentric contraction of the dorsiflexors. You need concentric contraction of the plantar flexors, but you need eccentric contraction of the dorsiflexors for you to drop the foot quietly down. If not, you are going to slap it on the floor. You understand? So those are the things that are used to facilitate gait. Where is the problem? Which muscle is involved? What contraction of that muscle is missing? Then you train those things. Then you see a better gait pattern. So this is just an example. Yes. So this is all about eccentric, concentric, muscle contraction, the percentage, the range of motion, and so on. I think we have taken a lot of time. I didn't even demonstrate any exercise for math and for this also the activity of muscles from which range, from which activity, from which part of the gait cycle that we have, which muscle and which contraction is involved. This also the various contraction of the muscles. This just in the stance phase, we could see from 0 to 60%. That means it's a stance phase. We don't have the top that is showing the other part of the information, but we see here is stance phase. Yes, this is also the same thing. So I have a lot of information. So you can read. I mean, on this, I think if you understand, I think when you come to gait facilitation will be much more important, or much more on that how you will comprehend more with all this. You could see what position those things are, the energy expenditure, the speed, and we don't want to take time on this. So taking us back a little bit to documents I showed, yes, the document I showed last week on documentation for gait. I quickly rush and stop this because I know a lot of questions will just be coming. So that's why I just skip it. So we could see the various stages of the gate or the phases of the gate. There we could see initial contact. Can you see it there? Yes. Initial contact. I know those things were not making sense when I was presenting last week, but now they will make more sense. We have the initial contact, we have the loading response, we have the mid stance, we have the terminal stance, we have the pre-swing, we have the initial swing, we have the mid swing, and we have the terminal swing. So you document where is the problem, you tick there on the yes. So you now go and see what you want to work on those things and improve on the particular problem. So let's look at the facilitation now proper, having done so much English. Okay, so yes, so I think the document will make more sense now. Yeah. So how do we facilitate gait? We have mentioned right from mat exercises, right from our pouches that we manage patients. We look into the arm swing. We look at the trunk, the various exercises we involve trunk. Trunk is strong, then we are going to have a better gait pattern. The pelvic is strong, you're going to have to do that. Various movements, strengths in the trunk, coordination in the trunk. We train for that. We'll see improvement. So this can be done in sitting, it can be done in standing, it can be done while walking. So in standing position, what do? We start. Most time in PNF, there is a stabilization of position. Then there is also approximation in that position. It's for the patient to, we have said that will help in stimulating the proprioceptors, exteroceptors, proprioceptors. So we always apply approximation, stabilization for the patient to be feeling that particular position and also learning and improving on that position. Then stand in a stride position or activities while one leg standing or shifting weights or various activities that we can carry out. So we can ask patient to walk. We can do it while walking forward. We can do it while walking backward. We can do it while walking sideways. We can do it while walking cross step forward or cross step backward. All those things can be done. Then facilitation, like I mentioned, we can give approximation, we can give a stretch, we can give resistance, and usually it's at the iliac crest. This approximation or resistance can be given for the patient. We have seen in the picture where a patient is transitioning from position. Like when I was demonstrating the exercises for mat, we could see patients transitioning from half kneeling to upright position, standing. I could see the physiotherapist giving resistance at the hip, yes, giving resistance. So various ways can be done. So this is a patient. We could see on the picture that the physiotherapist is giving stabilization at the pelvis, or is giving stabilization at the scapula, or at the shoulders rather. So it's making sure the patient is stabilized, is erect, is symmetrical, all those things. So you can give those stability or stabilization in these various positions. In Bobarts, you say key point of control or something like that. But a key point of contact or key point of control. But this is PNF. You can also give the stabilization at the shoulder or at the pelvis to make sure the patient is in a proper position and also maintaining that position. So this posture that we can see, the patient is okay. Maybe I will discuss that later. Yes, shifting weights. Ask patient to shift weights by standing on one limb or pushing the individual to the other side to make sure he's bearing weight on the affected side. Okay, I see. Let's make some demonstrations.
We are certain.
From the presentation you mentioned, I know it is not purely new.
Okay.
I think
It's on.
Okay, video.
Yes, I've just on it now.
Maybe you come to the other side. Okay, let's start with this one first. So we have mentioned
That's your man.
Yeah?
The lights. What you can see it.
we have mentioned approximation. Give first.
Germany.
There's just one trunk activity I also remember. Sorry, just sit down. Sorry, So you're taking us back to trunk. And just cross your hands like this and ask the individual to also flex and rotate to one side or flex and rotate to the other side. This is also trunk, something like this. So you can also, yes, you can also give resistance while the patient is going, either anterior or posterior, or you can apply any of the techniques. Just like yes. So we have stance face, we have swing face. I know we've been doing this in the clinic. So you ask patients, for example, sorry, let me take this. We usually ask patients on our steps or staircase in the clinic, yes, for them to do stepping.
Step.
And sometimes I'll ask people that when you ask patients to do stepping, what do you want to achieve? They'll say you want to improve stepping and all those things, and I'll say okay. So what this cycle? Which muscles?
We are targeting legs.
Which contraction? Which are contraction and so. So we need to be specific, very precise in the management. Let's if we ask patients, just like what we have a picture standing, just can you replicate the movement? It's making there. You can see there, she does this. Oh, yes, because they cannot see the slide. So you see there, you see the physiotherapist is giving approximation in that particular position. Can you guess what we are facilitating? Anybody can make comments, even those online too. They can write, or maybe they can
write
and make what's part of the gait cycle we are facilitating.
Practical.
To really open, maybe we should go to the side.
Perfect.
Yes. Stance. Which, with reference to left foot, we are facilitating stance face, mid stance.
Let's see the message chart.
We are facilitating the mid stance.
Yes.
With reference to left lower limb. It's mid stance. And that's why I brought this. That when you ask your patient to stand and do stepping, if the affected lower limb is the left lower limb, for example, we're asking the patient not to do this, he's able to maintain the posture, he's able to stand, and he's able to do this. So you are facilitating this stance. If he's able to do this, you'll be able to get about 30% of out of 100% of your gait cycle. Because if you look at stroke patients, the moment they bear weight, they don't want to bear weight on them. One of the major problems they have is stance face and this stance. They have a shocking stance face. That's why you see a poor gait on stroke patients. The moment they are walking, apart from what we see at foot drop and other things, they have shortened stance face.
Yes.
They don't want to bear weight.
They don't bear weight. The moment they bear weight, they are going into the next, they are going into the unaffected. The moment they bear weight, they are going to the unaffected. So if you measure their step length, all those measurements, and even you don't even have to do those, you obviously see that they have shortened stance phase, especially the mid stance, because the moment you go there and they go back to the unaffected, they don't shift weight. So that's when you can do the weight shifting.
Okay.
Yes, to make sure the patient is bearing weight on that. You can make one leg stance. You are also facilitating mid stance.
Yes.
Yes, you can. Yes, you can hold the couch. That's also the stance, right?
Yes.
But in the mid stance, let's finish up with the stance. In the mid stance, as we have initial contact, we have loading response before we have toe off. Oh, but we have flexion of the knee and hip. That's when you ask individual just stand. When you ask individual that as they are standing now, can you ask patient to squat, for example. This is which phase of the gait? This right lower leg.
Like this, 45.
Yes, if you just go flex and flex on.
Oh, is that? That makes sense. And loading to go.
Okay. Now, still on the picture there. As she's standing there, if the reference is the, let's say, my right foot now, then we are working towards
Swing.
Swing.
is the end of the
Stance phase.
Stand first.
Beginning of swing phase.
beginning of so you want to train swing face, the last station to doing this stance is you are training for
Swing first.
swing face. If the patient cannot do it, just stand. Patient cannot do it. Let him feel it, how he's supposed to do it. You have the history, you give approximation on the history. Approximate.
It will even improve for perception and canning.
Well, you know, every time we're stimulating for perception, receptors. That's the name of the tech. That's the name of the
Facilitation.
So you facilitate. You give approximation that this is what I want you to do. Yes.
So they are not saying, right?
So do it here. Okay. So
yeah, for the cement.
yes. This is his strength. But we are going through swing face and back to the end of stance face. This beginning of stance face, end of stance face. You go through swing face to the beginning of stance face. You go back through swing face to the end of stance face. Right? So let's see another participation. Yes, I'm yes. You can see here the picture here again is what? Is the D1. D1 lower limb D1 pattern.
Yes.
Which is functional in walking also.
Yes.
You also want to train swing face. Oh, for example, the patient is on the is on the parallel path, of course. Yes, you can see. So you are trained on the mat or on the couch. Yes, we have trained the one pattern. So you can see it's also training the swing face of the lower limb. You can see there on the picture. Yes. Swing face. Yes, this is not what I just demonstrated. You can see the patient is coming through from. This is if you look at the left foot, yes, the person is crossing and going back. Can you see it? No. So this is forward walking. Then you are going to be giving resistance, or you are going to be giving approximation. So you walk. No, you are going to be walking anteriorly. You're going to be giving approximation. From the picture is pure. All you want to do is want to be develop confidence, perception. So by giving the approximation, so while the patient is going forward, the patient is walking backward. You also give approximation while it's going backward. So move backward. You're good if you get it. So walking sideways also. You also give resistance. So move sideways, not to towards me. Yes. Yes. Also give approximation while you are placing your foot on the floor. Yes. Then you also go step sideways. So step your legs towards this. Then you also step back. Back, you step back. So you either step forward, yes, or you step back. This is you step forward, or you also step back. Understand? You give approximation, yes. So you can give the approximation also here, or you can give the approximation at the pelvis. Yes. So, for example, the problem is swing face. For example, you see our patients, they have foot drop. I'll be telling them to making the stepping, for example. But when they go through the step, they go into concentric contraction of the
dorsiflexus.
The flexus. But what about the eccentric contraction of the flexus? Is also another thing that they have challenges. You ask them to do, you also see to have that challenge. So you also train for that, or it's also part of the lower limb pattern. Just sit. Also part of the lower limb pattern, yes. This, I've mentioned initial timing, which you normal time the Have you saw there?
Mm-mm.
Saw it on the mat. Patient can. While also sit.
Later.
While all standing, we give resistance or coordination up. Stand up. That is
Yun ang mga sitwasyon. Elizabeth, it is a
to stand up.
So they did not get the time for emphasis or the deflection. Okay.
Let me demonstrate back. Just slide down. This is the one pattern. Yes, we have flexion. We have this for the. We have from plantar flexion to dorsiflexion. So even while patient is lying, sometimes for you or in spine line or inside line, you are facilitating the ankle activities even before he stand up. So you go into dorsiflexion and plantar flexion. So you can choose to apply combination of isotonic or you want to apply any of the technique.
where
All of them.
All of them you want, yes, you want to apply. So
connected.
let's go up. This is also facilitating it because this is the normal pattern of walking. Yes, that's what we saw with the lady when she was standing there on the parallel bar. Yes. So, but you are not dorsiflexing your. You start from plantar flexion. You come all the way with dorsiflexion. Yes, and go back with plantar flexion. Go with dorsiflexion. Yes. Plantar
Try to
flexion.
connect and see what it's showing.
Dorsiflexion. Yes.
Let's see what it's showing.
How do you train gluteus medius? The gluteal muscles.
All I do is that I look at it as
How do we train
lateral rotation.
the
I
gluteus?
Yes. I resisted lateral rotation. I took the pressure lateral rotation.
But what are the other functions they have?
Hip extension.
Hip extension. So what do you mean? For example, I'm just going back into muscles now individually. For example, bridging. Yes, bridging. We do bridging. We are strengthening the gluteus.
The gluteus, yes.
If that's where is the problem, then we strengthen the gluteus. Yes, that way we have good aspect of the gait where you need to go. Yes, we have various activities that you can do. You can resist the bridging. Yes, and bridge and ask the patient to cross and also resist. Yes, you can make it difficult, placing compliant objects on that, maybe a ball or something, make it compliant. The cushion or something that will make it more difficult to maintain the yes. So this is for quadriceps. What about hip joints? How do we quadriceps? Strengthen here. Yes. How about hip flexors? Yes. It is strengthening
Shall I off now?
Yes.
It is not majorly the knee. The knee flexor. It is not
I mean, even the plexus.
Right.
Now, let's go up. Yes. This is eccentric and concentric contraction of the hip flexors. Yes. Yes. individual muscles, you can go and train, you put them together. You also have pro line also, just like what we did for the S. Let's you can apply a combination of isotonic, for example. Yes, then you change the position. You do this is against gravity, against resistance. You can do it without resistance. I mean, without you do it gravity counterbalance sideline, just like what we have done now. So let's and facilitate. So you see, you are coming back. Okay. Each individual muscle, where is the problem? You will now see if it's a weakness, you facilitate and strengthen it. If it's a coordination, you also train for the coordination. Which technique will you apply to help in coordination? You also do that. Cross movement. Cross movement.
But again,
So we have done that with, together with
she don't know.
teaching. What about at times where they have you stretch or activation to legs. You stretch. When you stretch, you get more contraction of muscles. So that is the technique. Yeah. You stretch. So you stretch or let me say it's best described for lower limb. So can you come down? It's so you want to apply, stretch, and there. But this is initial stretch. But there'll be time that you just want to stretch all through. You have a stretch at the beginning, and you'll be stretching all through the movements. Unlike where you just have initial, you just have stretch and you ask patient to go on. But you have re-stretch. Stretch, 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 stretch. I'm doing it slowly so that, but slowly. You stretch, then there will be contraction. So that you have more contraction. So you give instruction to the patient that when you stretch, you contract. When you stretch, you contract. When you stretch, you contract. So you want to have more contraction. So when there is not much contraction you are seeing during the treatment, then that's when you give stretch. If it's all through, you're having problem. So you'll be giving stretch all through. Till the end of the pattern.
This is going for flexion. What about extension?
Yes, extension too. The same thing. Have a stretch. Also have stretch. You have stretch. 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 Also.
Is there a specific way to train with triceps? Instruct
No,
triceps
it's not about training. It's about you give stretch because you need more contraction from the muscle. That's why you give stretch or approximation. You also keep approximation you want because you want to have more input. You have failed the approximation.
So patient will kill the joint.
Fail the position of the joints, the
Nowhere
muscles that are in that very particular position. So that's the stretch. Okay. I think we have talked about replication last week.
Yes.
It's one of the easiest technique. Replication. You ask the patient if the problem is having, if patient is having problem with finding position, the perception, for example, you take the patient to a certain position, you go through, maybe your intention is to go through anterior elevation, you take him to anterior elevation, that's patient to push against, to hold, yes, hold that position, hold, push, 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 push. After some seconds, now say relax. That's the patient if you're able to find out that for that position. That is for you to replicate that position. So that is the technique of replication, which is also an agonistic technique. Yes. So the other thing is hold lax and contract lax. Hold lax and contract lax, they are the contract lax is for when there's tension. When there's tension, there's shortening of muscle.
Sir, someone asked a question. Please, how do you stretch when the patient has subluxation?
It's it's contraindicated. We can't do that. Stretch is contraindicated in so many things. I have it here because I'm rushing things.
Okay.
Unlike last week, we have discussed many things and details. That's aside, just to talk, just so that we can have something. It's already 4 o'clock now.
So to me, let him manage it.
You have to manage by shoulder stabilization with the scapular pattern, various movement of scapular pattern, various exercises to improve on the shoulder subluxation. Because it's because of the weakness of the muscles. That's why that's
Subluxation comes.
If that improves, then you can go to other technique.
Okay.
So, but hold lax is when you have pain. It's when you want to increase range of motion with pain. Contract lax is when you want to increase range of motion when there's shortening. For example, somebody is on QOP for long, when there's shortening, or is immobilized, for example, it's like shortening. That's when you apply contract lax. Hold lax. Yes. Hold lax is where you have pain and you want to increase the range of motion of joints with pain. So you apply hold lax. Yes. So one of the difference also, I'm trying to bring the two things apart. Yes. For contrast lax, you have dynamic movement of the joints or the muscle you are involved in the activity. But in hold lax, the name is hold. There is no any movement. Everything static. Static movement in hold lax. In contrast lax, you have movement, just like we have in dynamic stabilization, dynamic reversal, and stabilizing reversal. In dynamic, we have movement. In stabilizing, we don't have movement. So the same thing. Contrast lax, you have dynamic movements. You have movements that will occur, but in hold lax, both of them. There are even though contract lax too has to also direct and indirect. So let's forget about one. Now, hold lax also have direct and indirect. Both of them, you don't have movements. Everything is static. You understand? So I'm some ways how we have this family and the dynamic model you have movements. That model you don't have the same thing. Another one thing that appreciate the major the hold lax and contract and pascal. The contract lax you have dynamic movements. In fact, this is the structure you will see. So the range, so like I said, is when there is shortening, I want to increase range of motion because of shortening. So increase both passive and active range of motion. That's the goal of both contract lax. and relaxation of agonist. So the situation is that the patient performs active movement against resistance in the joints. To make movement against resistance, so the therapist changes grip and asks the patient to contract his muscles towards the agonist. You understand? So we tell him like pull. You go towards the agonist.
Pull, pull.
You have to determine the agonist.
Not pull.
Where is the shortening muscle? You understand?
Let's say the biceps.
Yes.
They are mostly
Yes. So you now make movements against resistance.
Sorry, I'm putting on
Yes.
you extend the elbow against resistance.
Yes.
I'm using antagonist.
I'm sorry. Let's go against resistance.
Extension.
Yeah, flexion against resistance. You resist, but we go against resistance. Then I'll change grip. That is the instruction. I'll change grip. Then you go now in the direction of the agonist. Then you will give instruction like pull.
Now I'm going against resistance.
Yes. You have instruction like pull. Then after some seconds, in fact, some say contract relax is you give resistance and the patient got tired. That's what they said.
Fatigue.
Yes, that is the aim. Self-fatigue, then to allow for
rest.
for movement. If the muscle is fatigued, then what else? Then you have chance to do all your movements you want to do.
Okay.
You understand? All the problems you have, persisting tension, all those things, because the muscle is contracting. But when it's relaxed, then you have all spasm. It's because there is contraction. But when it's relaxed, then you're able to have your own movement. So that is the aim. If you check the Sherrington's principle, this is the same muscle allowing for fatigue, or antagonist allowing for fatigue. That is the whole relax and contract relax. You understand?
You are not after strength. You are after elongating.
That's what I said. You want to increase range of motion. That is the aim of relaxation techniques. Hold relax and contract relax. You want to increase range of motion. That is the aim. You understand? So, but for the hold relax, you have different approaches. You have direct and indirect technique. So, like I said, most of them are for pain, even though they can also increase range of motion too, but they are for pain. So you have the direct one, which is called the post-isometric muscle relaxation, or Sherrington principle 1. The second one is indirect. You know, when you say the Sherrington principle 2. So the instruction is the patient is in comfortable position. Painful extremity moves actively or against the optimal resistance towards the painful position. This is the position that is painful. So you ask the patient to hold. For example, this is the painful joint. Then you go. You are experiencing a static contraction. Hold. Okay. For about 5-6 seconds. Then relax. Okay, let's see if you can go further. Then also and relax. You get it? Yeah. Then we have the indirect, which is the reciprocal inhibition. This one is you use the antagonist to bring the relaxation of.
What about patient with knee pain? How do we?
Everything is about the pain. You find out which is the direction of the pain, which is the muscle involved in the pain. Then you find out which way you want to bring about. If it has to do with tension of muscles, it's the muscle that is bring about the pain. Because everything here is out of contraction of the muscle. If the pain is not from muscle, then it won't help much.
Yeah.
You have to know whether it's a contractile component or non-contractile component. It is when, because there is tension in the muscle, that's why there is that pain. then that's when you can bring in the relaxation techniques. Understand?
Thank you, sir.
I'm sure you are happy to be.
Are you doing?
You just let me respond. So thank you very much for the responses and for the question. Yes, for hold, relax, like I said, and contract relax is when there is pain, that is when you go for hold relax. But when is tension, for example, is persisting, sometimes there could be pain, and sometimes there could be also the tension that is the hypertonicity that is preventing the movement. So whichever way, you will now decide on which one to pick. Is it that there is a pain? You want to relieve the pain, then before relieving the tension. So which one you want to go first? You want to relieve pain, you go for hold, relax. You want to relieve an increased range of motion. You want to release the tension, then you go for contract, relax. Thank you very much. I just want to mention that some of the pictures I've taken, I've shared in my last year workshop of this same PNF. I shared that it is a book which is freely available, PNF in Practice by Suzanne Adler. It's a very comprehensive textbook. I know sometimes it's difficulty understanding the basics, but I believe if somebody have little things about the PNF, if he's able to open the book, we're able to understand many things now. So you can search the book, is available online, is free. PNF in Practice by Suzanne Adler. I think it's published in the last edition. I think that is I don't know whether that is the newest one, but the one that is available online, I think it's published around 2008 or so. So you can get this information. Some of this picture, almost half of them I've shown, they are from that book. So this just to reference, just to acknowledge the author. Yes. Then the other pictures are from the course I have taken. You see a name there, Rehab Plus, is the institution where I had the training. Yes, I'm going to send the slide to Ray Institute, and they're going to share with you. There'll be no problem. I shared it last year, and I'm going to also share it. I think this year is more in depth with more information. Last year there were no many things there. It's just a few things that we had because
Just one session.
yes, and it's just one session, just 1 day, just like this is supposed to be 2 weeks, last week and this week, but we repeated what we did last week, almost halfway. Then we also have few about the addition. So thank you very much. If there is no any comment or question, maybe we can end the session. Thank you very much.